Good morning. Thank you all for joining us bright and early for this breakfast with the investigators. We'll be discussing new advances in multiple myeloma. I'm Betsy O'Donnell from the Dana-Farber Cancer Institute, and unfortunately, Dr. Love is unable to join us at ASCO this year, so I will be moderating in his absence. I feel a little bit like Ryan Seacrest trying to fill in for Dick Clark. I'm joined today by my esteemed colleagues, Dr. Fonseca from the Mayo Clinic, and Dr. Mateos from the University Hospital of Salamanca. Thank you. And these are some relevant disclosures for the faculty and the commercial support for this program. An important reminder that this educational activity does contain discussions of non-FDA approved uses of the agents and regimen. For official prescribing information, please refer to the product's approved indications. This is just a compendium of some of the different discussions that will be had and have been had throughout the ASCO meeting. We do have several sessions left over the course of the coming days, which we invite you to participate in. All right, so this conversation has really been informed by a number of 50 different consulting oncologists who Dr. Love reached out to, soliciting their questions about what the most relevant questions within myeloma are for those who are in practice. Today we will feature videos from 10 of those oncologists talking about important cases, the questions and challenges that arise. Our session today will be divided into 3 modules. The first will be led by Dr. Fonseca, where he will be discussing the approaches for newly diagnosed multiple myeloma. The second by Dr. Mateos, where she will be discussing the role of CAR T cells and bispecific antibodies in the care of patients with myeloma. And finally, I will be discussing the role of other novel agents and strategies in the management of relapsed refractory myeloma. We'll begin with Module 1. So we'll first be hearing a patient case. This is an approach to first-line therapy for transplant-eligible patients with myeloma, and we'll talk about the potential role for minimal residual disease in interpreting and making clinical decision-making.
Good morning, everyone. I'm Neil Love from Research to Practice, this year participating in ASCO virtually, and over the last few weeks, we conducted a survey of 50 general medical oncologists in community-based practice to ascertain their interest in the various topics we're considering presenting at the meeting today, and in particular to suggest questions and cases to present to the faculty. We picked 10 of these physicians to chat with us and recorded one-on-one Zoom recordings for about an hour each with the kinds of questions they wanted to direct to the faculty. We'll be showing excerpts of these during the meeting and asking the faculty on the stage to respond to these questions, beginning with one of the most discussed issues in the management of multiple myeloma, upfront management.
72-year-old male, he owns a body shop for the cars and, here in Florida, he's a very busy guy. So in any case, he developed right rib fracture, and that's what led to discovery of multiple myeloma, standard risk myeloma. He was seen at a higher institution initially, and he was advised that he should proceed with induction therapy followed by transplant. So he came back locally, and I started him on DRVD regimen. He completed around 8 cycles, and then he went back and they said, well, let's collect your cells and let's, plan for transplant. And he just, declined to proceed. I decided to de-escalate the treatment, drop the bortezomib, then continue DRD. And he's been on it for 18 months now. And, one wonders, looks like it's a pretty benign regimen, but it really is not that benign. It eventually leads to a lot of URIs and upper respiratory infections. And now with this new MRD assay, the clonoSEQ, is there any role? So I did do that test, not knowing what to make of it. There was some underlying monoclonal gammopathy, but it's hard to know with the IgG kappa disease, whether it's due to daratumumab being that kind of an antibody, or is it an actual disease? So in any case, he had some minimal residual disease. Do we de-escalate treatment?
All right, so we're going to begin with some questions for our faculty. And so for Dr. Mateos, in which situations are you currently employing daratumumab in your upfront patients who are transplant eligible?
Thank you very much. Elizabeth, and I would say that in my clinical practice, I do utilize daratumumab as component of the upfront therapy for basically all newly diagnosed myeloma patients transplant eligible. Our standard of care is daratumumab in combination with bortezomib, lenalidomide, and dexamethasone, approximately 4 induction cycles, followed by transplant, consolidation with 2 additional cycles, and maintenance with lenalidomide alone. Because although the Perseus study showed positive data with the use of DARA as maintenance, it is not approved yet, so we proceed with the len maintenance.
Mm-hmm. Dr. Fonseca, how about you?
Yeah, I pretty much do the same, and as you'll see in my presentation, I have a slide that I say pretty much everyone should consider or should be using daratumumab for frontline therapy. So in a patient like this, we do it as part of the standard of care, and we can talk more. In my own practice, I use daratumumab KRD as a standard of care for most patients. With close attention, of course, to toxicity. We'll talk a little bit more about that. But I think the data is really overwhelming that you need to have an upfront CD38 antibody.
Absolutely. And what about your choices for maintenance?
So it's very interesting. Maintenance was really validated through the studies and through the meta-analysis at the time where a lot of patients had residual disease post-transplant. I mean, many of those patients were being induced with 2 drugs. So one would say, well, no surprise, more treatment was effective. So now I have a true conflict of interest in my mind, which is like, on the one hand, I think if you're MRD negative post-transplant, how much benefit do you get from maintenance? On the other hand, I see the data from Perseus, and I go, people who get DARA-RD are doing great. So shouldn't we have maintenance for all patients? That has been shown for ALL as well, too. So I think we need to figure out a little bit better how we're going to tailor approaches to maintenance as we go into the future.
And so you mentioned you're using DARA-KRD for your transplant-eligible patients. What about your transplant-ineligible patients?
Well, I like to use the terms as I use in law, like, beyond any reasonable doubt or preponderance of evidence. To me, it's beyond any reasonable doubt now that the best regimen for the transplant-ineligible patients is the Maya regimen. Now, we're going to see more here at ASCO with novel approaches to that, but as of now, that is the standard for our patients.
Absolutely. And Dr. Mateos, how about you?
Yeah, so for the transplant ineligible, at the beginning we started to use daratumumab in combination with VMP because Dara-Lendex was not approved. And I have to say that we proposed an observational study in Spain prolonging the maintenance with the daratumumab by the addition of bortezomib. So Dara VMP, 1 year, followed by daratumumab plus bortezomib, 1 dose every 15 days. And we are going to analyze now the data, but it seems that apparently the progression-free survival is going to be prolonged. But definitely once Dara-Lendex was approved, and this occurred a couple of years ago, all of our patients right now are receiving daratumumab, lenalidomide, and dexamethasone. And what we don't know is after ASCO, well, we are going to have maybe the possibility of discussing about the potential role of quadruplets for the transplant-ineligible population. I personally consider that we are moving definitely to a frailty-adapted therapy. The quadruplet combination is not going to be eligible or feasible for all transplant-ineligible patients, but maybe for fit patients, maybe the quadruplet will be standard of care.
And I think that this is a really important question, actually, particularly when you think about the high-risk patients or a very fit transplant-ineligible patient who's ineligible based on age. Are there specific populations for whom in the transplant-eligible population you are giving the 4-drug regimen?
In the transplant-ineligible?
Yeah.
Yeah, so maybe for me, the fit patients. Mm-hmm. The fit population, the problem is how to define the fit population. And maybe we are going to see the INROD data tomorrow, and we will see how the hazard ratio does evolve throughout the different cutoff age, because the population is between 65 and 80, and I would be interested seeing if the hazard ratio is maintained even in the population between 75 and 80, for example. But in Spain, we conducted, and we are ongoing with a phase 3 clinical study only in fit patients, and the fitness is evaluated throughout a geriatric assessment in hematology scale, that it does evaluate different domains, including the nutritional status, the physical activity, the mood, the nutritional, the polypharmacy, the Charlson Comorbidity Index, and so on. And we realized that the quadruplet, in our case DARA KRD, was especially effective for the very fit population.
Yes, thank you. And it looks like now we have another case, and we'll be looking at the effectiveness of single-agent daratumumab in older patients with myeloma, and then thinking about the sequencing of these two different anti-CD38 monoclonal antibodies, daratumumab and isatuximab.
Multiple myeloma has always had a separated track for patients who are elderly and very elderly, and Dr. Eric Rupart has a 90-year-old woman who exemplifies the challenges of patients in this age range.
90-year-old with newly diagnosed myeloma. It was found because her primary care doctor did routine comprehensive metabolic panels, found that her creatinine was 2.5. And she was symptomatic with anemia, hemoglobin in the 8 range. So the question I have for your faculty is, for the very elderly, do you ever use daratumumab as a solo agent? My experience is it's incredibly well tolerated, and the response rate is very, very high, even as a solo agent. So I'm curious if your investigators are using daratumumab as a solo agent.
What did you do with her?
I gave her Dara solo, and literally within 4 weeks, her kappa-free light chain dropped from 1,000 plus to nearly normal. It's just such a great drug, and no side effects whatsoever. She just didn't have anything. I'm curious where your investigators are sequencing isatuximab. Does it work after daratumumab? Is there an advantage of isatuximab over daratumumab? Are there different scenarios where they use Dara and where they use ISA?
All right, so we have two important questions here. It's the decision-making between the two agents, and then also this question of single-agent Dara. But let's start by talking about how you decide between the two and what factors you consider. Dr. Fonseca.
Thank you. Right now we have very little information that would allow differentiation between, efficacy and safety. They seem to be quite comparable. I think that's what most people think. Practicalities have played a major role because the sequencing of approvals, familiarity, and certainly for DARA has been the upfront availability of subcutaneous, but we're going to have that very soon with isatuximab as well too. So I think the answer is very shortly, we consider them quite equivalent for the moment.
Dr. Mateos?
Yeah, I completely agree. I think that there is not any head-to-head comparison between isatuximab and daratumumab. Honestly, I think that it is not necessary. Both are anti-CD38 monoclonal antibodies, and I would say that the efficacy is quite similar. Well, how to proceed in the clinical practice in Europe and in Spain, we do follow the approvals. So we can't use isatuximab in first line because it is not approved yet. But by contrast, in Spain, we have to utilize isatuximab in combination with KD or in combination with PD at the relapse because we can't use DARA in this situation.
That's a great point. Thank you. All right, so now we're going to move on to you, Dr. Fonseca. I believe we have our slide presentation for this module.
Okay, well, thank you very much, Dr. O'Donnell. I'd like to just briefly review some of the most recent and relevant data. A couple of conceptual points. One is, although you read that myeloma is an incurable disease, survival is much longer. There's 3 series there for large academic centers or systems where if patients get ideal therapy, it shouldn't be unusual to have 10 to 15 years survival. And I actually personally talk to my patients about our attempt to cure their disease. So that's currently what we're doing, which on the left was when I finished training melphalan and prednisone, barely over 2 years. Now I might say this is probably one of the most important slides that I'll share with you. For me, the upfront treatment of myeloma has been simplified, and it has only 3 steps. The first step, as of today, is everyone should get their RD. Now, this might change with the addition of ISA and the data we're seeing, but first of all, everyone gets their RD. Step number 2, you decide if someone is a transplant candidate or not, and if they are, then we add a PI, and then we go through the procedure of going through stem cell transplant. And step 3 is what we're going to be discussing more and what comes out with IMROS. Your patient is not considered now to be a stem cell transplant candidate, but maybe they're fit enough that they're going to benefit from the addition of a PI. And then on selected circumstances, you add a PI. So despite all these drugs, to me, it can be very simple how we go about now selecting therapy with less emphasis on the dichotomy of transplant candidates versus not. Now, to me, the other thing is I would say is the ultimate goal of all myeloma upfront therapy must be to achieve MRD negativity. I won't go through the details, but this graph just depicts the progression that we have seen in our ability to achieve MRD negativity with frontline therapy. Some of the cynics might say, well, it's just biology. Those that are doing well do very well. It's true that plays a role, but unless biology is changing, this is the evolution with the availability of better therapies for myeloma, which in fact we can also see that in the transplant ineligible as well as in the relapsed and refractory setting. Now, relevant data that I'm sure you're aware of, but just to put it in the context of what we're going to be discussing, of course, Mateos, which is now the largest clinical trial, phase 3, that looks at the combination of daratumumab with VRD upfront compared with VRD with a transplant, then with 2 cycles of consolidations, and then with this unique aspect of maintenance where if you receive the DARA upfront, you're going to receive it as part of your maintenance, with the option that for those patients who are in a CR and maintain at least for 12 months the MRD negativity can discontinue therapy with daratumumab, they can start it down the line. So more and more we're moving towards more time-limited and adapted approaches for patients. Now the PFS has been published as well too. As you know, they're at 4 years is close to 85%. So it really sets the stage based on a phase 3 study for some of the best outcomes that we have ever seen for patients with multiple myeloma. So for me at this point, I don't find a justification where patients should be induced with a triplet. I think unless someone has an allergy to daratumumab or isatuximab as we move forward, all patients should be receiving treatment with a quad regimen. Now, the most important metric I mentioned again is, I'm going to say it because you can get criticized for this, safely, but safely achieving MRD negativity should be the goal of myeloma therapy. On the left side, you see what we see in Mateos at the threshold of 10 to the minus 5. On the right side, 10 to the minus 6. And what you can see is with passage of time, you just continue to see a deepening of the response. And sure enough, there are exceptions to this, but the cascade goes from responses to MRD negativity, which results in better PFS. And if we had sufficient follow-up and number of patients, we would undoubtedly see that translating in almost all of these trials to improvements in overall survival. And now here, for the overall on the right side at 10 to the minus 6, 65%. That is the benchmark now. The best regimen should be achieving about 65% MRD negativity when they're treating upfront transplant-eligible multiple myeloma. Now, another study, which you're aware to as well as the master clinical trial, the permutation here is instead of being bortezomib, is carfilzomib based. This is the data from Dr. Costa, and although the slide is busy, I'll explain it to you just very quickly. On the upper part, 10 to the minus 5, the bottom part, 10 to the minus 6. You have these clusters of columns. On the far left is all patients, and then they're split into those that are standard risk, high risk, and ultra high risk, meaning 2 or more cytogenetic abnormalities. And you can see several things. Of course, if you are more stringent, it's a little bit less with 10 to the minus 6, which is the bottom part. Number 2 is the depth continues to evolve and gets better over time. But number 3 is an important point, is as we go forward, you see that we see differences in the MRD negativity at 10 to the minus 6 more clearly than we see that at 10 to the minus 5 in the ultra high risk. I think that's where the money is for the interpretation of this clinical trials. But if you take 10 to the minus 5, 80% of patients, below it, 10 to the minus 6, at best point, 66% of patients. Now, this is the data for ISKIA. ISKIA was presented at ASH as a late-breaking abstract. It's the same schedule now as with isatuximab, same thing with the transplant. And again, MRD negativity on the right side, again, 10 to the minus 6, you see that, it's at first glance, it appears to be pretty similar across the various groups. But what you see is that for patients who are only getting the KRD and half the 10 to the minus 6 tested, there's a huge difference in the ability of produce those deep responses, which again, we think will translate into longer-term control of the disease. Now, there's more data that is available, although some of this is still evolving and it's early on. One of this is the HD7 study, which is a German study of ISA RVD versus RVD with transplant. And then there's a second randomization, which, by the way, I'm a fan of second randomizations because the way you can ask the questions in the same clinical trial. And what they reported for the first part of this trial, the intention to treat, looking at the 10 to the minus 5, again, the superiority in achievement of MRD negativity. Now, with more follow-up, we're seeing that over time, again, this continues to get better. So I will say, and this is a common question, well, are you using MRD in your clinical practice? In our practice, we use it routinely, and we use 10 to the minus 6 at the threshold. We inform patients, and in fact, we make clinical decisions based on our ability to obtain 10 to the minus 6. I will just mention this briefly. I made the point when we had the conversation about the patient. Maintenance was approved when initial therapy was suboptimal. So we need to go back to the drawing board and understand how we're going to do maintenance approaches. I think it's critically important that I'm not showing this today, but that for patients with high-risk disease, if you're able to make them negative, you significantly diminish the prognostic effect of those high-risk markers. In some series, it appears to be eliminated. I'm going to say it's probably never eliminated, probably it's a little bit less, but it's very good. And so I think the idea of LEN maintenance, which is the standard of care, we have a meta-analysis, remains, but this needs to be challenged. In my own clinical practice, if you're MRD negative 10 to the minus 6, I still offer maintenance. And this is just one example, very briefly, of a patient. And it just shows you the different time points, how we track things. This patient, was transplanted, had first KRD, then, we put him on some consolidation with their RD, had to discontinue maintenance, and you see it has a little blip back into positivity. He's put back into maintenance, and he stayed at this level, which is essentially 10 to the minus 5 negative, 10 to the minus 6 positive. So it's just a quick example of how we're doing this. We have other studies. I'll just mention briefly Maya, which, as you know, has a PFS of 62 months. But the real excitement that we have at this meeting, and we can't talk much about it yet, is IMROS, which shows now the 4 drug combinations. So that's a 3-step on this decision process that I showed you in my orange slide. And all of what we know is that clearly the response rates and the MRD rates are much better. We want to understand the TAEs, of course. We see that for grade 3. Also, we see some grade 5. I'm very curious to see this presentation. But really, the question is now out there, should more patients who are transplant ineligible get a quad as well? And I think with that, I'm going to conclude, Dr. O'Donnell. I'm just going to say the Cepheo study is similar design, but this is with daratumumab, but we don't have the readout for this, so I'll leave it at that.
Thank you so much. That was a wonderful presentation. And so for this, we'll now move on to Module 2, and we'll be discussing the role of chimeric antigen receptor CAR T cells and bispecific antibodies in the care of patients with myeloma, and Dr. Mateos is going to lead us in this. We'll begin with a case. This is the management of toxicities associated with CAR T cell therapy and with bispecific antibodies.
Tolerability issues in the use of CAR T therapy and bispecifics is paramount in the management of these patients. And our consulting general medical oncologists have many questions about this, particularly the management of cytokine release syndrome.
I'm very interested in knowing the day-to-day management steps of CRS. For example, once the patient has, for example, teclistamab infused, then what are we watching for and at what time points? The kind of protocols that we have laid out, it's very different to actually go through it and have that call 4 hours later and a patient has a temperature, let's say it's 101, and then now you're wondering, okay, what should I do now? Should I get them in clinic? Should I tell them to go to the ER? I need to get some vitals. I need to get some blood work. So being able to get a sense from those who have managed CRS and how to manage it in the community, making sure that all of the stakeholders who need to be involved have had the right training so the infrastructure is there too. I think it's something that for my community, we're still catching up on.
We know that patients who receive CAR T therapy often are very hypogammaglobulinemic for a while and high risk for infection, but that often goes away after a period of time. However, with bispecifics, patients are on continuous therapy and may remain at high risk for infection. How do investigators manage these patients, monitor them for infection? Do they give these patients prophylactic antibiotics or antimicrobials? And what is the role of IVIG therapy in these patients? We need experience managing ICANS and neurological toxicities. So I'm interested in hearing how investigators manage these toxicities, when they use tocilizumab, when they use steroids, and I think partnering with academic and community settings together so that patients can potentially ultimately be treated in their communities.
All right, so we heard a variety of really important questions from the videos, and we have a couple of other ones directly here. So I'll begin with Dr. Mateos. For patients for whom you decide to administer CAR T, how do you choose between the two available CAR T cells currently?
Well, a difficult question, but we are going to imagine an ideal scenario in which we have a patient eligible for whatever of the two BCMA CAR Ts, and we are going to have a slot available for both CAR Ts. And I would say that in principle I would select cilta-cel. Basically, in a regular patient, triple class exposed or even triple class refractory, basically because although cross-trial comparisons are not appropriate, it's true that cilta-cel resulted in a median progression-free survival of approximately 3 years. ide-cel resulted in a median progression-free survival of approximately 9 months. But of course, this is in the ideal scenario, the patient would be eligible for whatever of the two CAR Ts. But imagine that we have to incorporate maybe also the safety profile. We know that cilta-cel resulted in potential late neurotoxicity, so this can potentially influence, and if we review the prior medical history of the patient and the patient has some neurological problems, or we suspect that if this occurs, the situation for the patient is going to be more challenging, why not to select the ide-cel? It's true that in the real-world experience, in an analysis presented by Dr. Surbini at us, showed how in the real life, to be older than 80 years was a prognostic factor predicting outcome after ide-cel. So maybe in the more elderly population, if we want to preserve the safety, ide-cel is one possibility. And another possibility to complement maybe the efficacy of ide-cel will be to complement with the lenalidomide maintenance low dose, and maybe we can extend the durability of the response.
Thank you. Wonderful. And so, Dr. Fonseca, given the recent FDA approvals for cilta-cel and ide-cel earlier in the treatment landscape for multiple myeloma, at what line of therapy are you currently referring your patients with myeloma for CAR T?
That's a great question. So I think we need to be very attentive to all the information that is coming forward with regards to the toxicity. But given what we know today, I am comfortable with offering CAR Ts for the first relapse. And that's what we have started doing in our clinical practice. As I mentioned, we're very attuned to look at long-term outcomes, toxicity. There's some questions with the secondary malignancies that have come up. By the way, I don't think that T-cell lymphoma amounts to almost anything. We've looked at that data independently, but there's the data for the MDS. To me, the most important one will be just to make sure that we stay very low, as it is reported right now in CARTITUDE-4 for Parkinsonism. If that stays as it is with the growing number of data, then I think it makes perfect sense. And one of the most interesting things, and we're sharing about this before the meeting, is the one-and-done aspect. So we see the patients, they complete the process, they come back, and I tell them, I'm going to be checking your labs, but I'll see you in a year. I mean, to do that for a myeloma patient that's been coming twice a week to a center is just absolutely wonderful. And patients saying, this is the best quality of life I've had in a long time. So we'll see where we go with that.
Yep, absolutely. And so, Dr. Mateos, going back to you, in what line of therapy are you typically employing bispecific antibodies? And I hope that in your talk, too, you'll be able to touch on some of the questions that were asked during the videos, because I think there were some really important topics brought up about immunosuppression with these. So I'm hoping that both of you might touch on that as well.
Yeah, so in Spain, we are utilizing the BCMA bispecific monoclonal antibodies, either teclistamab or elranatamab, in patients after at least 3 prior lines of therapy, triple class exposed. So we can utilize in the 4th line. It's true that for me, from the general point of view, when a patient is triple class exposed, could be potentially eligible for bispecific, but we have to respect the guidelines, the approval, and we have to wait the patient to receive at least 3 lines of therapy.
And Dr. Fonseca, maybe you can comment just in terms of your decision-making between CARs and bispecifics.
Yeah, for the same reasons I alluded, we have been more biased towards use of CAR T, but the bispecifics play a critical role in some patients, like patients who have various comorbidities. I think of a patient we had with severe coronary disease that we elected to go for a bispecific, and the patient had a MRD negativity just in a few months. It was a wonderful response. I think part of this is going to be the practicalities. Many in the audience know that bispecifics are now being approved for solid tumors. We have one for small cell lung cancer, and I anticipate more will come. So I think the use of bispecifics will have to become bread and butter for the community providers. I know we still hear this comment, but they will be everyday treatments in the future of oncology.
It's very exciting. All right, and now we're going to move on to our next tutorial from Dr. Mateos, who will be talking about the role of CAR-T and bispecifics.
Thank you very much. And you know that today CAR-Ts and bispecific monoclonal antibodies are basically targeting BCMA or GPRC5D, ideal targets present on the surface of the plasma cells. At the beginning, BCMA CAR-Ts as well as bispecific monoclonal antibodies emerged in order to cover the unmet medical need we had for the triple-class refractory population. ide-cel was evaluated in this KarMMa phase 2 study, 128 relapsed refractory myeloma patients, but important to note, 84% were triple-class refractory. The overall response rate was 73, the CR rate or better 33, the median progression-free survival 9 months, and the median overall survival 20 months. These data covered the unmet medical need we had. In terms of safety profile, we know that CRS is going to occur in more than 80% of the patients, but if we know very well how to manage it, it is going to be grade 1 and 2, basically in the majority of the patients. ICANS is much less frequent and not superior to 20%, also grade 1-2 in majority of the patients. Infections can occur, of course, as well as cytopenias, but they are going to be restricted in the time because CAR-T is single infusion, and we have to prescribe adequate prophylaxis, but of fixed duration. And approximately 3-4 months after the CAR-T, the patients basically remain free of disease and in many cases free also of treatment. The next step was to evaluate ide-cel in earlier lines of therapy, and this is the KarMMa-3, evaluating the role of ide-cel in patients after 2 to 4 prior lines of therapy. And ide-cel was compared with the different standard of cares. From my point of view, I would like to remark from the KarMMa-3 that in spite of the fact that the population was earlier pretreated and the median number of prior lines was 3, it's important to remark that almost 70% of the patients were triple-class refractory, and the unmet need does exist regardless of the number of prior lines of therapy. And indeed, the control arm resulted in a very short median progression-free survival, only 4.4 months, and ide-cel was superior with a median progression-free survival of 13.8 months. Overall survival at the beginning was not positive, but it was in relation with the crossover. And over 80% of the patients cross over to receive ide-cel at the moment of the relapse. Cilta-cel was also evaluated in the CARTITUDE-1 in approximately 100 relapsed and refractory myeloma patients. But again, note how 88% were triple-class refractory. And I would say that this is the common denominator for all these studies. Cilta-cel was very effective, and we previously discussed the median progression-free survival was almost 3 years, and the median overall survival has not been reached yet. For me, it's important to note the MRD negativity rate and to see how there is a subgroup of patients, approximately 18%, that sustained the minimal residual disease negative over time at 2 years. And I consider that this is going to be the main driver of the excellent outcomes in terms of progression-free survival. Safety profile is also predictable in terms of CRS, ICANS, but we have to take care with the late neurotoxicity that occur in the CARTITUDE-1, but it's true that strategies were implemented in order to mitigate it. Unfortunately, not many new cases are emerging in the new clinical trials. And Dr. Fonseca pointed out the safety profile. Second primary malignancies emerged, but I can imagine that patients in a similar situation in other studies would not be at risk for the development of second primary malignancies because of the expected outcome. CARTITUDE-4 was the phase 3 clinical study evaluating cilta-cel in patients after just one prior line of therapy, 1 to 3. The main characteristics is all patients were refractory to lenalidomide, but a few patients were triple-class exposed. The benefit is present here in terms of progression-free survival as well as overall survival, with a hazard ratio of 0.4 for PFS. And in the overall survival, it is a great surprise for me to see how there is like a plateau phase. Of course, we need longer follow-up. And this is what we are going to have in the future, CARTITUDE-6 and CARTITUDE-5 evaluating cilta-cel in first line of therapy. Today, ide-cel and cilta-cel allocated in the triple-class exposed and refractory patients. Ide-cel is available in patients after 2 prior lines of therapy. Cilta-cel just after 1 prior line of therapy, and in the future we will have also CAR-Ts in the first line. What about bispecific monoclonal antibodies? Here you see how there are 4 BCMA bispecific monoclonal antibodies under investigation, and teclistamab and elranatamab are already BCMA CD3 monoclonal antibodies approved. Basically, all patients were also triple-class refractory. The overall response rate is approximately 60%. The CR rate nearly 30-35% or higher, almost 50% for some of them, and the median progression-free survival can be between 1 year, 16 months, indicating that in all cases, I would say that BCMA CD3 monoclonal antibodies cover again the unmet medical need we have. But in terms of safety profile, CRS is going to be also present in between 60 and up to 70% of the patients. Again, grade 1, 2 in majority of the cases. It is predictable because we know, for example, according to the question planned by the oncologist, the median time to CRS after teclistamab is 2 days, and the median duration of the CRS is 2 days. We have to consider that the step-up doses are going to mitigate the CRS, and it would be even possible to investigate about the prophylactic use of tocilizumab. ICANS is going to be very infrequent, no more than 5 events in the different trials, and the problems is going to be cytopenias around the first cycles, but infections as well as hypogammaglobulinemia, and it is absolutely necessary to prescribe prophylaxis, at least antiviral prophylaxis, anti-PGP prophylaxis, antibacterial or antifungal if the risk for this type of infection is high, and supplement with IV immunoglobulins in order to maintain IgG over 400. Other target, GPRC5D, the monumental one evaluated the role of talquetamab, bispecific monoclonal antibody that at the dose of 0.8 milligrams per kilo every other week resulted in 70% overall response rate, median progression-free survival of 14 months. And this cohort of patients included patients treated with belantamab mafodotin. And there is a specific cohort of patients previously treated with CAR-Ts or bispecifics. And this is giving us an idea about the appropriate sequencing. If we prescribe first CAR-T, talquetamab later on worked very well. If we start with bispecific monoclonal antibodies, again BCMA, the sequencing with talquetamab is effective, but you can see how the efficacy is a bit inferior. Safety profile for talquetamab, we have to consider the on-target of tumor toxicity, skin abnormalities, nails abnormalities, taste abnormalities, I would say manageable, and basically very few patients had to discontinue because of this. In the future, many potential combinations for bispecific monoclonal antibodies, and as CAR-Ts, bispecific monoclonal antibodies are allocated today in the triple-class exposed population. In the future, they will move to earlier lines of therapy because the phase 3 clinical trials are ongoing, and in the future, we will have BCMA and GPRC5D bispecific monoclonal antibodies in the first line of therapy, even as induction in the transplant ineligible or as maintenance after autologous stem cell transplantation. So if we have to envision the future, maybe we are going to maintain PI, IMiD, Sunday, CD38 as induction, but we will utilize bispecifics and or CAR-Ts, and maybe we will be able to cure patients with myeloma throughout these strategies. Thank you.
Thank you very much. And it's really remarkable just how many studies there are in this space and just the rapid development of these innovative strategies. So now we're going to move on to Module 3, the incorporation of other novel agents and strategies into the management of relapsed refractory myeloma. I'll be leading this session. I think it's a really important one. Coming on the heels of what we just heard about our immunotherapies, we have to remember, and we've heard from some of the community providers, that much of this is still done at our academic centers. And so what are the options for providers in the community beyond immunotherapy? So we'll begin with some videos.
General medical oncologists have now accumulated a great deal of experience using the BCL2 inhibitor venetoclax in the management of chronic lymphocytic leukemia and acute myeloid leukemia, but have many questions about the use of this agent in patients with multiple myeloma and T1114 translocations, beginning with the indications for the use of this agent, what to combine it with, and how to manage it from a tolerability perspective.
Are there any biomarkers or any other tests outside of 11-14 translocations to determine which patients may best benefit from venetoclax, and also which agents to partner with venetoclax, and what is the correct dose of venetoclax? And do investigators use ramp-up dosing in myeloma, or do they go straight to the dose that they want to use?
How about your 57-year-old woman with T1114?
Recently started her on venetoclax in addition to the DARA-KD, and she's having an excellent response. She does have a lot of side effect with the carfilzomab, and she's very, very tired, and it's hard for her to do her work, and just overall not feeling well. So we're planning to stop the carfilzomab and to continue with the DARA-VEN treatment for her, given that she's having such a great response. I will be interested in hearing the faculty's comments on how to ramp up venetoclax in this setting, whether tumor lysis is a concern in patients with multiple myeloma. We started with 50 and then we ramped up on her dosing, but we actually did not observe tumor lysis, and we did check the tumor lysis labs, and she was hydrated, but she did very, very well.
All right, so we'll begin with some questions, and I think this is a really important one. If you have a patient who has a translocation 11-14, when are you thinking about using venetoclax, and what are you partnering it with? I'll begin with you, Dr. Fonseca.
Thank you. I wish I could use it at frontline, but I don't yet. Although I have used it in primary refractory disease. I have patients who have had a primary refractory and primary plasma cell leukemia with wonderful responses. I had a patient who had an allergy to lenalidomide, in whom we switched then to Dara-CyBorD, middle response, and Dara-venetoclax, and amazing response. The patient became MRD negative. So we're using it mostly at the time of relapse, but most of the time we have seen that it works best in combination. I think the best combination right now reported is Dara-venetoclax dexamethasone. There's a study that was presented at IMS by Dr. Kaufman. I believe they have close to 80% PFS at 4 years in patients with 11-14. So it is a good drug, but I think it works best when it's helped by other agents, because at the end of the day, it's just something that mediates with the process of apoptosis. So I hope there's a path for venetoclax and future BCL2 inhibitors for this subset of patients.
Great, thank you. And so, Dr. Mateos, beyond those patients, are there any for whom you are thinking about using venetoclax, any patients with BCL2 overexpression that might be appropriate? And really, are you able to use BCL2 overexpression in your clinical practice?
Well, in clinical practice, I think that the starting point is if we wanted to use venetoclax, we have to focus on patients with 11-14 translocation. And based on the FISH analysis, I think that it is basically worldwide available, and for me this would be the first take-home message. We can evaluate the expression of BCL2, but the problem is that there is not a standardized technique in order to evaluate it. On Tuesday, Dr. Ballis, on behalf of the CANOVA study, will present the data of venetoclax dexamethasone according to the BCL2 expression, and we will have the opportunity to see how venetoclax and dexamethasone is equally effective in patients with BCL2 high levels or low levels. It's true that numerically, the efficacy seems to be better in patients with overexpression of BCL2. But from my personal point of view, in the clinical practice, it is not necessary to go to the expression of BCL2 in order to prescribe venetoclax. And the 11-14 translocation is present, we can move forward and to prescribe venetoclax.
That's great, thank you. And this is our next video, where we're going to talk about the integration of selinexor alone or in combination with patients with relapsed refractory disease.
Selinexor now has a defined role in diffuse large B-cell lymphoma, myeloma, and perhaps in the near future, endometrial cancer. General oncologists in the community-based setting have had experience with this agent and many questions about where this will fit in and how to maximize tolerability.
With the recent approval of CAR-T and bispecifics, I wonder where selinexor may fit in. I think initially with the higher dosing of selinexor, I think many oncologists were nervous about using the drug. Now we know the drug can be very effective at lower doses, particularly when partnered with other agents. I'm interested in finding out when investigators use selinexor. Do they use it in earlier relapse? Do they use it in later relapse? How do they dose the agent? What supportive care measures do they use in order to keep patients on therapy? And what do they think the best partner is with selinexor? I use low dose Seli. I think it's much better tolerated. In the community setting, if you have a 85-year-old who's not going to CAR-T or bispecific or not interested or doesn't have the right functional status, when they get to third or fourth line, it's one of the agents we use. I always partner it. So I partnered it with a CD38. I think there's good data to support that. I've used it with bortezomib and I've used it with colfizimab. I haven't used it with a immunomodulatory agent. I think when I use the 40 milligram a week dose, I think it's quite well tolerated.
Yeah, so let's begin, Dr. Fonseca, with you. In the treatment sequence, when are you thinking about selinexor for your patients and what are you using as a partner?
Yeah, just a couple quick comments. I think knowing how to use it makes a world of a difference, whether it's a tolerable drug or not. And we actually, have been able to use it in patients of advanced age. Somewhere between 40, I more often go with 60 and triple antiemetic prophylaxis, and we can do that. Often combined, like I said, with carfilzomib. Right now, because of the advent of bispecifics and CAR-T, we prioritize those agents. But there's patients that either have been through that or are not fit for a trial, et cetera, where they have prior exposure, and this can be a drug that can actually be quite effective. One of the interesting points where we have used it is in bridging therapy. And some of the patients require bridging therapy. Oftentimes they haven't seen selinexor, and we use that, say, with carfilzomib or daratumumab as a way to get those patients to the next step.
That's great. And so, Dr. Mateos, what is your schedule? What kind of a dose are you using? And how are you preventing adverse events? I know this morning before we started talking, we had a nice discussion, the three of us, just about really thinking about less is sometimes more, and how do we manage dosing so that we ensure tolerability and efficacy for our patients in the long run?
Yeah, I think that it is possible to utilize different doses of selinexor, and selinexor does combine very well with whatever standard of care. We can utilize selinexor in combination with VD based on the Boston study in patients after just one prior line of therapy. And the starting dose planned in the study was 100 milligrams. But we realized that maybe 100 milligrams is quite toxic. And indeed, in the Boston study, it was analyzed that the subgroup of patients who had to reduce the dose to 80, and the tolerability was better, and at the end of the day, it resulted in a better efficacy. So my recommendation maybe would be to start with 80. It is not necessary to start by 100 milligrams. But for example, if you combine with pomalidomide, and we are participating in an European Myeloma Network trial, selinexor, pomalidomide, and dexamethasone, 60 milligrams is fine. Recently, there is a publication with a very small phase 2 randomized study, selinexor pomdex 60 versus 40, and it seems that 40 is even better because maybe of the tolerability. And at the end of the day, for selinexor, I think that it is more important the cumulative dose than the dose intensity. And if the patient is able to maintain on treatment with a good safety profile, at the end we are going to see a benefit in progression-free survival. We have to take care about the safety profile, and I would say that especially during the first 6-8 weeks, it is mandatory to prescribe dual anti-emesis in order to control the side effects and to inform and to educate to the patient about the nutritional status they have to try to intake food in order to avoid loss of weight. And we have sometimes to hydrate very well in order to avoid hyponatremia. But I think that throughout education of the patient, it is a drug that it is quite well manageable, especially because it is possible to modulate the dose.
Yep. All right, and now we have another video we'll go forward with, and this is looking at dose reductions or the potential elimination of dexamethasone as a component of myeloma therapy, and I know many patients would love to hear that.
We complete our rapid-fire tour of questions from the community in terms of management of multiple myeloma with a long-standing question we'd just like a little bit of an update on: the optimization of the use of corticosteroids in this disease.
One of the big questions that's on all of our minds, which is, how can we minimize the dosing of dexamethasone? Because it is something that all community oncologists recognize. Dexamethasone is not a well-tolerated drug. It is a poorly tolerated drug. In fact, if I give VRD or anything with daratumumab, it's usually the least well-tolerated of any of those. And of course, we give these massive doses, and I think we do so, my personal feeling is, without really much data. I'm curious whether your investigators are using lower doses of steroids in their myeloma regimens. Is there a role ever to have no steroids? So for example, my 92-year-old woman with minimally symptomatic myeloma, could I just give her Dara alone and not have her take weekly steroids?
Is that what you did with her?
I gave her 12 once a week, and after I got her pretty close to remission, which she already is, I've got her down to like 8 milligrams once a week. But to be honest with you, I'll probably end up tapering it off because she doesn't complain at all about the Dara, but she does complain about the Dex. Her complaint about the Dex is interesting. She likes how she feels for 2 days after getting the Dex. Monday through Wednesday, she's, as she puts it, she's useless. She just can't do anything. And I think that's not an uncommon complaint.
Yeah, so absolutely, that's not an uncommon complaint. And I think we heard earlier in this program a question about whether or not we need dexamethasone with daratumumab, particularly in our older and frail patients. And I think, less is definitely more. If you have patients who are experiencing side effects from their dexamethasone, it is absolutely appropriate to taper, if not discontinue. And particularly when we think about use with daratumumab, if you can get through the first couple doses, I think it's perfectly appropriate to back down and potentially eliminate the dexamethasone. All right, so now we are going to move on to my portion of this presentation where we're going to talk about the incorporation of novel agents and look at some of the data for the findings from the phase 3 studies of Icaria and Ikema, looking at isatuximab in combination with standard doublets. We'll look at some of the efficacy and safety data for selinexor in combinations with proteasome inhibitors and other agents, and we'll look at the biological rationale for venetoclax and some of the other venetoclax combinations that we alluded to earlier. And so what you see here is the Icaria data where we're looking at the combination of isatuximab with pomalidomide and dexamethasone versus pomalidomide and dexamethasone, and you can see very clearly the separation of the two curves for progression-free survival, favoring the triplet at 11.53 months versus 6.4. It significantly improved the progression-free survival with a trend towards improvement in overall survival. Looking at isatuximab in combination with carfilzomib and dexamethasone versus the doublet alone, we see, again, significant separation of the curves with a progression-free survival of 35.7 months for the addition of isatuximab to carfilzomib and dexamethasone. And this was a planned analysis with a distinct progression-free survival advantage. So we've talked a little bit about selinexor, and I think one of the attractive things about this, which was not mentioned, is that this is an oral agent, and it specifically targets portin-1, which is a major nuclear export protein. And what selinexor does is it inhibits this, which keeps tumor suppressor proteins and oncoprotein translation and reactivates the glucocorticoid receptor in the presence of dexamethasone, which we know has tumoricidal properties in multiple myeloma and may also enhance daratumumab daratumumab activity in myeloma cells. It was initially improved in combination with dexamethasone in 2019 based on the STORM data. There we saw an overall response rate of 26% with a median progression-free survival of 3.7 months. And I think what's really notable were the GI adverse events, specifically nausea and vomiting. But I think what we've seen since then is, just as we've talked about, the ability to combine selinexor with other agents, modifying the doses with great success. So the Boston study looked at selinexor in combination with bortezomib and dexamethasone in comparison to the doublet. Here you see that selinexor was dosed at 100 milligrams once weekly, and that bortezomib was also delivered weekly. It was given weekly for 4 weeks on and 1 week off, and bortezomib was given on a standard twice-a-week schedule. But what you saw here again is separation of the curves with a significant improvement in the progression-free survival of 13.9 months versus 9.46. But what was, I think, most important here is that there was 40% less bortezomib given and 25% less dexamethasone given in the triplet versus the doublet, and yet still you saw this improvement in the responses. In the STOMP study, selinexor was added to carfilzomib and dexamethasone, and we see here that this was in a population of patients who had a median of 4 prior lines of therapy. Almost all of the patients were lenalidomide refractory and heavily pretreated, and the median progression-free survival for this combination was 15 months. And here again, the dose went down on selinexor, and we achieved excellent efficacy with once-weekly 80 milligram dosing in combination with carfilzomib 56 mg per meter squared once weekly. Next, the STOMP study looked at the combination of selinexor with pomalidomide and dexamethasone. Again, all of these patients had been heavily pretreated. 100% had seen lenalidomide, and the dose here was 60 milligrams. You can see the trend. We've gone down from twice weekly to 100 to 80 to 60. And the progression-free survival here in a population that had already seen the immunomodulatory class of drugs was 10.4 months, with an overall response rate of 65%. And so there is an ongoing study, an EMN study, phase 3 study, and the dose that was selected to move forward comparing selinexor was 40 milligrams with pomalidomide and dexamethasone versus elotuzumab with pomalidomide and dexamethasone. This is an important ongoing study. And then we move on to venetoclax, which we've talked about. Translocation 1114 is the most common translocation. It's present in about 16 to 24% of patients with multiple myeloma. BCL2 is an anti-apoptotic protein that promotes cell survival in patients who have this translocation. So the idea is that venetoclax, which is highly selective and an oral BCL2 inhibitor, would be appropriate for this population of patients who have this translocation 1114. And what we see here in the initial studies was even in single agent, there was activity in 66 patients with a median of 5 prior lines of therapy. 45% of those patients, which is unusually high, had a translocation 1114. And we did see an overall response rate of 40% with single agent venetoclax. Since then, it's been used in combinations with dexamethasone, for example. And what I'd like to highlight here is the separation in the curves. And we heard this from Dr. Fonseca earlier, that when patients respond, they have durable responses, and it works quite well. In the Bellini study, this has become a very important and famous study. This included all patients, and initially we saw a tremendous progression-free survival benefit. However, over time, we saw the overall survival did not favor the venetoclax group, but that was an all-comer. So when we look at those who had T1114, what we see is the significant separation of the curves with a progression-free survival of 36.8 months for those patients receiving venetoclax with bortezomib and dexamethasone versus those receiving placebo, bortezomib, and dexamethasone. And so, again, this rationale for looking exclusively in the patients with T1114, and we look again at venetoclax in combination with daratumumab and dexamethasone versus bortezomib, daratumumab, and dexamethasone. And here, 2 different doses of venetoclax were explored, and it underscores that sometimes less is more. The 2 different doses that were used for venetoclax were 400 and 800, and what you see here is that the progression-free survival was superior for the 400 milligram group. So it really highlights the fact that we can use lower doses, and again, some of the problems that we saw at the higher doses of venetoclax were infections. And so if by using these lower doses we can preserve the efficacy but potentially mitigate some of the side effects associated with this therapy, I think that's where we're really striking gold. And finally, this is venetoclax in combination with carfilzomib and dexamethasone. And again, we see outstanding efficacy in terms of the progression-free survival at 32.2 months versus 14.2 for the doublet. All right, so now we're concluding. There are multiple sessions left. We hope you will join us for those sessions, and greatly appreciate my colleagues here for their tremendous effort and counseling on the best ways to incorporate these wonderful therapies in multiple myeloma.
Thank you. And thank you to the audience for being here so early in the morning. We appreciate you being with us.
Thank you.
Thank you.